Intro to TMR.
Are we done with that?
We are done with that.
You're
I'll
recording?
turn this off for now.
You're recording.
I'm recording. Cool. All right. All right, so let's get into the thick of things. Let's get into the concept behind it before we get it to be active here. So, when you're in school and you learn to do a joint mob to this shoulder, what are you looking for when you go to assess it? You know, we're going AP, PA. What are we looking for?
Integrity.
Okay, integrity. And when you say integrity, what do you mean by that? What all does that?
Any restrictions?
Any restrictions? So where it's being tighter.
Tighter. What the mobility is.
The mobility, right? The quality, the speed. All right. Perhaps if they grimace.
The infield.
The infield. All right. And which one do we decide, or were we taught to go into to treat?
The restricted.
There's a restricted one, the most restricted one, correct? Was anybody taught to go into the most free direction? It's really neat. Were you really?
There were a few. There were, in other words, if we took the shoulder rotation, if you're having a difficult time with external rotation, work internal rotation.
Very good. Wow, that doesn't happen
Similar
every day.
problems in
Okay.
lower back problems too.
Yeah, strain,
Excellent.
counter strain goes.
Yeah.
Don't go there yet. I'm talking about back in school. We're still talking. All right. So you're
Not really.
professors, but
Yeah.
then I know it's been a while as far as that goes, and then we're going to work our way up here in a minute.
Yeah, I
But-
studied with strokes, like in Holland, when I was in Holland. Like,
Yeah, Holland does do.
For example, we start with, for example, PNF on the good side, that
Correct.
simulate to the other side.
Correct. And so Holland, it is done a lot of the opposite-sided stuff. A lot of times when you're in school, you're taught, oh, well, if this one's not working very well, come over and gain trust or something. And for some reason, they relax into it, and now this one will work better. But they didn't give it as this being the technique, at least over here. I may have over in Holland and stuff.
And PNF too.
In PNF, okay. Now, so we've been conditioned in the recipe that we were given to follow. Pretty much, if it was restricted in AP, which way did we go? AP, correct? All right. So I say, wouldn't it be neat if we just opened up the school to more of a scientific method, right? So how many directions are there? How many pure directions are there? There's actually 6, and I'll equate it in motion. But I can go forward, I can go backward, I can go side across, and I can rotate and rotate. Same thing, forward, backward. You're going to do side, or whatever happens, because you're going to rotate it. And then rotation. All right. From there, then, how come we weren't given all those as choices to compare? I know I was not. All right. So we never learned which one would work better. We were told which one would work better, right? And we practice in that direction. So when I teach students now, they are really caught into that frame. And it's almost like I'm doing something like that I need to have a study for to go to the good side, the good direction. And that's insane. Wait a second. We should have a study of why weren't we given all 6 directions to compare, right? And that's what we're going to do here, is open you up not just the 6 directions of the injured side, but the 6 directions of any joint in the body, and what will it do to whatever you're trying to fix. All right. So if we'd been given the opportunity, and again, the teachers, and it's not like somebody's maliciously trying to do that. It's just the way that it's been taught. But so if we were going in AP, and then we got an opportunity to go the other way, we'd see what it did. Correct? And then we could go to the 3rd most restricted and the 4th most restricted and just start comparing and seeing what we came up with. Because somebody went somewhere and decided from the shoulder we could go to the neck. Same philosophy, same recipe, but whatever's the most restricted. So we're okay with this to here. We weren't okay to this to here. All right? Now, and then we might be able to go into here, and we might go into the elbow some. When knee wasn't really thought of. Ankles weren't really thought of. All right? So from there, those 2 things were okay, but still into the direction of restriction. Strain, counter strain comes along. Oh, well, let's say Mulligan comes along. Brian Mulligan comes along. He goes, you know what? I don't care what way you push into the joint. Whatever way works to make that thing lift up, that's awesome. All right? Then you got the strains, counter strains come on. Basically, I'm not going to go through the way, that's what I did. But pretty much, let's go the other way. Let's go to the opposite direction. And then you got this comparison between Williams flexion and Mackenzie extension. But at least it opens us up to comparisons rather than say, hey, you know what, you got a disc, don't ever think about flexing. Because what way did it come in? So I'm going to run there here in a second. But it really is about comparing, which Mackenzie does very well, direction-wise. All right, any questions on that at all? All right, so when we did is because I was strain counter strain based, we began going into opposite motion. Somebody can't do this, right? They were strain counter strain was all about tender points and folding over them. All right, we began about motion. So if they couldn't go this way, what would we make them do? We started by going this way into the joint to see what would happen. So we took strain counter strain and made it functional. So I don't know why it wasn't done before that. All right, we took Mulligan, all right, and what we did is we said, all right, well, if this doesn't work, what about if we come push down here? What do we push here? What if we lift the leg up? What happens? So I say you can speed up the Mulligan part of it by going to other areas. We took Mackenzie and we said, all right, what if when we do the press up, what if we press to one side versus the other, which is exactly what they do when they press on you or make you strap to what used to be the old ironing board and then strap it down, is that when you press on one of those sides, basically what you're doing is you're forcing rotation to the other side. And so we just began testing things unilaterally, right? And whichever one was restricted was the cause that you couldn't go into full extension. It was the weak link. All right, so from there you go, oh, okay, that's kind of cool. So what we began doing is just testing motion, because everything, if you have a joint and it's torqued, will it show up in motion? Yeah, any joint that's out of whack is going to show up in motion. If you have a psoas that's tight, is it going to show up in motion? So what's the umbrella overriding all of it? Motion. And what can patients do? Motion. So now not only did we take it to something that was a bigger umbrella, but now we took it to anybody can test motion. And how are we going to determine what motion to treat them with? We're going to look for asymmetries of motion and see where the biggest asymmetries of motion are. Treat those out. Now, you'll see on the videos they're always treating to the good side, but who says we have to go to the good side? Let's set up the experiment. Let's try going to this side doesn't lift very well. Well, let's try going to this side and see what happens. Then let's try both sides and see what happens. Then let's try one side, the other side, and see what happens. So you see it's a scientific method the whole way. Now, you'll eventually drop off and you'll say, you know what, working the area of injury is not the quickest. But you got to get there. It took us a while to get there. All right? But we continued to test, and we began with lots of assessments. You know, I did a mechanical assessment, a strain counter-strain assessment. I was also trained in John Barnes. I did a myofascial assessment. You know, so, and we did the motion assessment. And that's what opened this thing up, okay? And there were things on top of those. Lawrence Jones from Strain Counter-Strain used to say, if it's crooked, make it crookeder. And what it was, if I came in looking like this, what was odd that I never could figure out is here's their crooked. He'd say, take them more into crooked, but he'd lay them down to do it. Why? Why did he lay them down to do it? Why didn't he just do it right there? So that was one of the first things I started playing with. I was like, oh, this is kind of cool. Let's just go further, see what happens. And it worked. Now, that's the opposite of Mackenzie, because it would be like, let's do the lock and key and see if we can get them back up and over to the anatomical position and get them up. Okay, again, it's about what works. But we began noticing that seemed to work faster. I was totally Mackenzie trained until then I took a strain counter-strain course. And I go, well, that's totally opposite of what I've just learned for the last 2 years. But it was fascinating because they took some failed McKenzie patients, just put them into flexion and it worked. And I go, oh, there's where Williams flexion and McKenzie works. And I'm bastardizing the idea of McKenzie to some degree because you test all sorts of ways. So please don't take it as that. I know where I'm coming from, but you get the general concept. Any questions on that? Now, each of those we can experiment with. We used to lay down and we'd make you do the shoulder and you test, whichever direction was the most restricted. And then you would go and treat it to most restricted. Then we'd go to the least restricted. And then we'd come over here and we'd do the other side, into the direction that this side didn't move well, into an AP on this side, and to see what would happen. It was wild. We just don't have the time necessarily for that. Okay. But I've got to take you back to a couple situations, because I've got to open up your mind and actually open up somewhat of what we found to be our own blinders, that I've got to make you see that you've got blinders on too. All right, so if somebody comes, and you also have certain fears that have been, again, ingrained in us, the recipes we were kind of taught that's the recipe, don't veer from it. So if somebody comes into you, bent over in back pain like this, we're thinking what's happening to them. Might be a disc, right? And what do you never do with a disc?
Flex.
But what are they doing?
Flex.
Is that crazy?
Yeah.
So let's look at, I'm going to start talking about the obvious. I'm going to start talking about observations. Let's really look at what happens. All right, so we have this thing that says don't flex when you have a disc problem. Or, you can say, well, don't flex more, right? But they're already coming in flexed. So I say to you, when somebody comes into you like this, whether you're a PT or not, again, this is ingrained in society. It's not just a PT thing. All right, what do you want them to do now? So they come in, what is it you want to do to them?
Straighten up. No.
You want to stand them up straight, correct?
Correct.
All right, so there's that knowledge base in the recipe part. That's where we've been trained. Which way does the body want to go?
Inflection.
Okay, down, perhaps. All right, so the first comment is, when I change the question, people say, oh, the body wants to go down. And I say, well, now we're in a problem here. Do we go up or do we go down? But most of you hadn't even thought about the possibility of going down. Because what? The recipe said to what? Not to do it.
Yeah.
Because what would happen if we did it? It would blow out the disc or something, right? At least by the time I came along. Okay. I know as you're back there being trained earlier, it was like you were playing around a lot more. You were experimenting a lot more. So from there, right, what are we going to do to determine what we should do? Why don't we just try it both? So have you ever taken somebody down like this or like this and saw what happened? All right, so I'm going to share with you the story where it began because I had no other option. All right, so I had a patient that came back the reverse way, like this. So what's that, the anterior disc derangement in McKenzie? And she was severe. I mean, McKenzie talks about one that he saw, and this lady looked a lot worse than what he was describing. And literally, came from a doctor's office. It was next door, and she wanted a therapy ball. She wasn't coming to see us. And she comes in the door lopsided, leaning over, and I was like, wow. And so I was McKenzie at that time, and I tried to, I call it the lock and key, that you're trying to laterally shift her and bring her up some, laterally shift and bring her up, and she's sweating and not too happy, and I'm sweating trying to figure it out real quick. And I said, this isn't working. I said, well, maybe your body knows something more than mine, or more than we do. So I don't have any therapy balls. So why don't you just lay over my back, or my knee, lay over backwards, okay? Because you just keep wanting to say you want to do this, so why don't you just lay over my knee? And she did. Now this lady came in on a Monday, she was scheduled for surgery on Friday. She leaned over, and she just sighed like, oh, that's heaven. She stayed there 2 or 3 minutes. She got up, and she was 80% better. It's like, ooh, that's kind of cool. Again, just a little bit of a idea. I was like, wow, that's kind of neat. Now, I said to her, you want to do that again? And she said, yeah. Now, this time when she went over, she was equally balanced. Her hands weren't touching, her feet were touching. I had all her weight. Right? And she stayed there as long as my knee could take it, my leg could take it. And she got it back up, and she was 95% better. I saw this lady 3 times. Right? The only thing is she came in the next visit, and her foot was really feeling sprained, and they wanted to say, oh, you pinched you got caught at a quantity, it's going down, it's doing all this other stuff, you really, really need surgery. She goes, you're not doing anything until I go back and see Bob. She never got my name right, so I said, okay, cool. So we found out that her problem was her ankle, and we went over, obviously trying to do this side, she was going hysterical, but we went and did this side, and she got in this funky position where she was up against the wall with that leg stretched out. Boom, that was it. We've talked to her about every 2 or 3 years. She'll call me up and refer a patient over or something. So that got me thinking, well, maybe I should not pay attention to the recipe so much, but I should have a safe way to explore whether that is right or not. Maybe I can experiment on my own. And then what we began doing is that literally, I don't know how long afterwards, but I was going to lunch and Chip was treating patients. Maybe it was else, and a lady came in, walking in the door like this, all right? And I said, oh, she was just so uncomfortable. And I said, will you do me a favor? I said, will you go down just a little bit? Because again, I want to be safe. I don't want to blow her disc if the recipe's true or not, right? So I go down, and she goes, oh. She relaxed, and she actually swore. And I go, what? She goes, well, the other word for crap, I've been thinking I have to stand up this whole time. And I've been fighting going down lower. And so I said, cool, well, why don't you then just go down like this, if that's the case. And she did. And she got up in 5 minutes, and she was 80% better. And I was like, wow, okay, maybe there's something to this stuff. So that's when it gave me enough confidence to break away from what my brain and my experience and my knowledge tells me and says, okay, I've got to start testing. Now, the thing was, here somebody's coming in crooked. Well, you guys don't really look crooked. What do I do about you guys?
I have crooked back.
What's that?
I have crooked
You have a
back.
crooked back, right? But if
Yeah.
you coming in, you're relatively looking crooked, or not crooked. Right? I mean, you might have a little, but it's like, oh, it's going to have to fight with that. So I have to do something here. I gotta open again some more stuff up. So here's a patient comes in. Abe. What's the obvious?
Oh, you accent?
Yeah.
Right.
Right, knee pain. What's the obvious?
It's a lot easier for him to step up with that left leg.
Okay. What's the obvious?
I think have weakness on the right leg.
Okay. What's the obvious?
Weak on the right side.
Okay. Lenny, what's the obvious?
Restriction and weakness on the right side.
Okay, good. Now, I asked what the obvious was, and we all gravitate towards what?
Side.
Problem.
The problem. All right? But how many obviouses are there, at least? There's 2. One works, and one doesn't. And you're going to get so sick, well, if you come to TMR2, you're going to get so sick of that, hearing that. What works, what doesn't, what works, what doesn't, what's comfy, what's not comfortable. All right? That there you go, is that we're so focused on what? Problem, area of problem, and which one do we address?
Problem.
Okay, now, I'm going to take that to, is that, though, what is obvious out in the, I'm not, well, as I say, I'm not smart enough to do rocket science. So I'm glad TMR is in my bag of tricks, because I just like to observe, all right? And this is one of the big things, is that is what we're doing what truly happens in nature? Is it the way if we have nobody out there doing medical stuff and you're in the woods and you're a gorilla or you're a deer? Does it happen the same way? All right, so I'm a deer in the woods and I sprained my back right leg. All right, what am I going to do now is I go to walk with that back right leg.
Hold it up.
Flex.
All right, I'm not going to put much weight on it, right?
Right.
Okay, so tell me the obvious things that are happening here.
The other limbs are taken over.
What does that mean?
They're-
Say what you just said.
The other limbs are taking over.
What do you mean taking over? Doing so. Let's place that into weight.
They're taking more weight.
Thank
Yeah,
you.
they're
So
taking-
this is not taking weight anymore. Therefore, it has to displace it over to the other three. That's just the obvious, right? Now, let me ask you something. Before I just made that example, why is the back right leg healing?
We're letting it rest.
We're letting it rest. That's what's healing it, we'll say. What else is happening that's helping it heal?
It's staying in the comfort zone.
No. It's the other. You're right, because if I cut you with a knife, right, and I don't want to go above there, I'm staying in the comfort zone that I can do. Okay, so the knife cutting is that I've got a comfort zone. I go above it, it hurts more. So I am staying in the comfort zone. But the other obvious is I'm doing what with the other three?
Working
Oh.
in there.
Placing more weight on
Right,
them.
yeah.
So what's helping this back leg heal?
Weight bearing on the other side.
So put those both together. Through observation, it appears that this right leg heals because of what?
Non-weight bearing.
Not weight bearing or less weight bearing on this one, and what on the other three?
Increase.
So could we set up that as an experiment to determine if we can make it heal faster? How? How can we set up an experiment now to see whether we can make it heal faster?
Let's try it.
Try what?
Well, give me a deer.
No. But we could be here. But how? No, set up the experiment. How can I make them heal faster?
Weight bear,
Weight bear what?
the right rear.
Okay, so we test weight bearing the right rear to see whether that give it a little bit more weight back there. So he doesn't want to have it down, so we can make him have it down, right? And that could be a way, which is the way we've done it forever, right? What else could we do to determine what'll make it heal?
Exercise the other ones.
Put more weight someplace, whether it's on all together, more on this, more on these two, more on this one, and see if those three, in some proportion, make this heal faster. But what's the only one we chose in our healthcare profession?
The problem one,
The problem one.
the obvious problem.
We only chose this. And therein lies what the blinders are. Nobody has gone over, right? We'll do the neck. We'll do from here. But if you just look at that, well, cool, wait a second. So really, if we're talking about a joint, all right? I'm going to make you work a little here, Mikey. Sorry about that. So you're going to want to flip it to here. If we're talking about a joint, we go whatever that is, and whatever this way, and up and down, right? Side, side, and rotate, rotate, correct? What we've got here all right. Let me draw this. Well, we'll do it this way. You've got left to right, correct? You got top to bottom. Where do your diagonals come in? Where do your diagonals come in? And what are they? What? What do they make up in us?
Obliques.
Well, our arms and legs. Now you're saying, how are they connected? They are diagonals. We are an XYZ axis. Why? Because we're three-dimensional. We're a three-dimensional being. This makes us three-dimensional. So when we're moving an arm and a leg, right, we're rotating. No matter what you do, this idea we don't rotate, come on. When they say, when you've had a fusion and stuff, don't rotate. Well, they're rotating all the time, and then years and years they freeze down here. So what we have here is a beautiful thing that we call the center of balance, center of gravity, the core. All right? So it's this core that when we go and sprain our right leg, it gets pulled down here. Would everybody agree that this leg's going to tighten up? Would everybody agree then that it's pulling? I'm not saying it's being displaced, but it's being displaced towards that direction. Right? And so, in order to stay in balance, what does this have to do?
The opposite side.
What?
Like the opposite
It
side.
has to go, look, what do we do? So if this doesn't get used, we still would like to have this up here. So we put more weight on this leg, don't we? So that displaces it to midline. But you're not back to center. So you might say, but look, I sprained my ankle. I've been using my left leg like crazy. How come it's not better? I go, it is better. You're just not up to the center yet because they haven't used enough what? They haven't used enough arms to bring them back up. They could use both arms too. See, those are the three other extremities. Bringing this back to center. What's the other way you can go? Right? You could use a lot more of the right arm, which you see people getting up, pushing off a lot in the arms. And then they could use equal amount of the other two to bring it back. Now, the whole concept of healing is happening. And it's only to do with mechanics. All right? Now, the other thing, wouldn't it be pretty? Maybe we could just use the other arm because remember, it's all connected. Now, you don't need any other of the theories. You don't need to know about nerves and figuring out complex things. We can use structure. Structure and function. Love that in pediatrics, right? This is structure and function. This is observing the obvious. We're not using a recipe. Even if we were using a recipe, our recipes need to be compared to things now. You have to recognize there hasn't been a lot of comparison. And the comparison that has been done may be just on the side or the area of injury. We need to get out of there. Cool? Now, keep it there. There is a turtle guy. We haven't even looked at manual, but there is a blue guy that looks like this. We call him the turtle guy. All right, it looks like that in the manual that we'll look at in a minute. All right. So, very quickly here, though, I just want to get. I'm always asking the patients, or I'm asking you guys, the students, what do you think about that? And I literally ask you individually. So, what do you think about that? You just heard that for potentially the first time.
I understand it.
You understand? Okay. Good.
I mean, after you finished that, I wanted to cheer. You know, I mean, it just. It
Why didn't
really-
you? That would have been cool.
I know.
You know?
But it gives you so many more tools on the healthy side of the patient, the part that they feel like they can use. I think of the kids that I know, you know, a kid that just had surgery and can't bear through one leg because it's healing, and the PT's still working on that leg, right? And it's hard for the child. And I just think, wow, I mean, he would be so willing to do these other things. And I'm going back and comparing Monday, so with the
There you
PT.
go.
So,
Awesome.
but it gives a whole lot of new tools that are so much more comfortable and could be so much more effective and make so much sense.
Thank
So.
you. Awesome. Nabil?
Well, with my patients, always I think also at the whole body because that's what I learned.
Because you're massage, and I mean, you're doing
The
tissue.
fascia
Exactly.
release, so I always put the body in harmony with the fascia release.
Yep.
So in my back mind, I'm thinking what you're thinking. I think, put it on paper, and I think it's very cool now to think about the other movement. But I look from the body like as a whole, and that's why I release
Exactly.
areas in the body.
And you're doing it, she's doing
Yeah.
it, and you're doing it
Yes.
manually when
Yes.
you do it that way.
Yes.
And then now you're looking at a function.
Yeah, I can
So
also,
other people
yeah,
can do it
yeah.
for themselves too.
And I did some, but not in that thinking in that area, what you are telling us.
Yeah.
But like with PNF and all that, and rotation and with the function of the body. So I'm working with that with patients too.
You are. You definitely are.
Yeah.
Massage therapists get this whole thing because they're using the whole body typically. All right. However, when it comes to function, which most therapists are doing, it is limited to an area. And you'll probably still say that you're focused on an area. Maybe, maybe not.
Yeah, correct.
yeah, so-
Correct. But like, for example, if somebody with back pain with my patients, So I go higher.
Yeah, you're going to know that you're going to go in the calves.
I
and you're going to go to
release
the
higher,
thighs,
and then I
you're gonna
go
to-
like with
Absolutely.
with my trigger points therapy, like soleus affect the
Exactly.
back, and I go to the calf.
Yep.
I do the other stretches to get the back better.
Yep.
So I work in the whole body, but it's not like focus what you are telling us, and that's great.
Cool.
I think it's pretty much the same thing. I always like to try to work on the triplanar function. With integrating the joints above and the joints below. However, I most of the time do that in a static
Mhm.
as opposed to dynamic or an active. And I think the integration of that is clearly evident.
Good. Excellent. I mean, we're there. I mean, lots of things are going now. We're getting away from parts, putting the bodies together in wholes, and making it functional now. I mean, it's really, truly, I think you'll see all the techniques eventually go that way. And then the education will go that way too. Lisa.
The best way I can describe it is it feels soft on the inside of me. So I'm looking at it, I'm thinking, that feels
Truthful.
right. Yeah, it just rings true. And I guess I'm looking at it from taking Susan's classes several times and trying to understand when my kids are on horseback how to take that and make that work as I have the three-dimensional movement of the horse moving forward. And I've had some trouble taking the formula, the TOTS formula, and making that work. So maybe looking at it from this angle, I can maybe combine the TOTS stuff with the adult stuff.
I'll take this for you. I'll help you.
Okay.
When the child is on the horse, ask them to lean forward. Ask them to lean forward to the side, to the side, to the back, to the side this way, to the side this way, and ask them which is more comfortable. Don't assume they should look like anything. Don't assume they should look like a normal anatomical rider on
Right.
a horse. It should
Right.
be about comfort, and they know where that is. And in fact,
That's
if
right.
if you'd be quiet and let them just ride with no indication of what they should look like, they will already naturally do that because kids don't care about what they look like necessarily.
No, they're not as
Okay.
locked in their fear
But
beliefs.
if they are, because some of them are, you'll believe it or not, they do try to be good little students too, all right, is they begin saying, well, lean this way, lean that way, and you'll notice. And if they're
Okay.
connecting with a horse, that's what's so neat about the horse and them, is they get comfortable on it, and then they will shift the way they need to. And then it's so dynamic that they're having their body, they don't have time to think, their body's doing it. That's what, the horse is taking away their mind. That's what's nice. And they just have to trust the horse, and they're worried about trusting the horse and doing that, and then they let go. And their mind's gone, and now their
Okay.
body's just working the way it should be. It's when you're sitting there and go, do this, do that, wait, no, it should look like this. That's the problem.
Okay.
Okay.
Well, this makes sense because the injury brings us out of balance, and what you're describing brings us back into balance, and it's looking at us like we are, which is a whole interfunctional being, rather than just the injury of that part.
Correct.
So this makes sense.
Awesome.
I think for me, what ties it in is that you don't look at it as an orthopedic problem as much as it is more a neurological problem. Trying to initiate movement where it doesn't want to go and then push movement into a direction that equals out what's going on in the core, what's going on in the whole body. So rather than just look at it as an orthopedic problem, more of a neurological approach. I mean, the only thing that comes to mind is when I have people walking, people with whatever problem it is, ambulatory, is utilizing hiking poles. If they shift it to one side and they remain shifted and they have a lot of restrictions, again, I'm walking with the hiking poles, and a lot of them will self-correct to a degree, but it's something that they can practice themselves.
Give you a story on that. I had a therapist that he would get the stroke patients after skilled rehab. So they'd already been in therapy for 3 weeks, and the first thing he would do, he'd put them on parallel bars, and he'd say, I want you to forget everything you were just taught, and I want you to walk the way your body wants to walk, and we're going to do it for 10 minutes. If they could survive that long or whatever, they'd rest and stuff. So if they were like this when they're doing it, okay, as they kept doing it, he'd notice that all of a sudden they're now becoming more anatomical by going further. So he'd go, it's exaggerated. So he did exaggerated. They'd be doing whatever they need to do. And by the time those 10 minutes up, he goes, wow, it was amazing the way they now look more normal than the 3 weeks in therapy. And then he goes, but Tom, then I would freaking go and do the traditional stuff. And he goes, I didn't realize I was doing something so cool there. So Chip, I don't know if you want to share something on that.
Yeah, I have to share. I have to laugh kind of when I hear y'all's answers a little bit, because either y'all are really nice or we've gotten really a lot better at explaining things over the years. Because I had the benefit/disbenefit of being in the embryology of all this, and so I come in and Tom, exciting, brilliant guy, but with a lot of wacky thoughts.
Jeez.
But we connected on a few things. The whole body connected thought. I had a lot of Gary Gray background type of that. I liked those types of things. But the whole, work the other side, things like that. As a sciencey kind of guy, I was always willing to try things. But I struggled with those thought concepts. And, you don't ever want to look like an idiot in front of your patients, too, trying something that might make no sense to them. Yeah, so it's interesting seeing this. I remember the first TMR one I ever taught. There's always a third of the people in the room who will shake their heads no matter what you say, and there's another third in the room who are going to be like, I don't know, convince me. And then there was always a third in the room that's always the smartest people in the room. They're going to fight you no matter what. But yeah, so you guys, I think we've come a long way at our ability to explain things, and maybe as a profession that we're a little more open up to other concepts and thoughts than maybe
We used to have lots of theories and we throw them all out there, and this is pretty much the only one we throw out anymore.
So if you see anything in this tool, I always say that's kind of brilliant and wacky and exciting, Tom probably created it. If you see anything that's really logical and makes sense, I probably created that aspect. I always say Tom's the Captain Kirk of Star Trek, and I'm the Spock. That's how my brain thinks. But it's funny listening to everybody here.
Margaret?
I think it would be a great tool, especially for the patient who feels pretty cornered. Like they've had a lot of bad experiences. They think they've got nothing to give. No, like this arm's not going to do anything. This arm's not going to do anything. It's like, okay, we're not asking it to. You got all these other parts that can do things, and I think it kind of opens up their hope again. Oh, okay, I am not a broken mess. I have many other parts that work, and I've just been thinking about this one that didn't. So I think that for patients who have just been really feeling let down by themselves, it's a great topic of conversation for them, and it's a great theory where they can get behind themselves again and say, hey, you know what, I can, I am a reliable body. I just only have one part that doesn't want to cooperate right now. So I think it's a really great tool. It's been obviously helpful to us, but I think you guys will find that it's helpful as well. It is.
For everybody actually involved. We did not get your name because you walked in late, so we all introduced ourselves. If you'll introduce and then answer that question. So where are you from?
My name is
Pam.
And I'm from Holly Springs. I work in Sanford, and I'm an occupational therapist.
Oh, yay!
And I saw this stuff on the website, the YouTube, and I was actually searching for myself for some, because of frozen shoulder. I have things that I was working with, and I thought, well, let me just try this with one of my patients. I was like doing an evaluation. I had like 5 minutes left. I said, oh, let's just try this fluky thing, and it was. He said I had pain cortisone shot 2 months ago. I said, and there was like limitations. He couldn't do twisting down below. Both arms were really not very good. I said, oh, let's just try it. And he had like pain out of 8 out of 10. And I said, well, let's just twist the upper part of your body and see what happened. And we went to the one side for 20 seconds, came back. We did the test beforehand, and did the 2 sides for 20 seconds. He goes, well, I can go a little bit further. I said, really? I'm like, really? He's like, yeah. I'm like, okay, let's take a look at your arms. And they were like, one up a little higher. And then I said, well, I'm looking at the clock because it's like, let's just try it one more time. He went 20 seconds, 2 times, came back, did the others like further. I said, well, let's check. Then he's like, wait. I'm like, what? And he goes, the pain is gone. I'm like, are you serious? He brought his arm up to about here, and the other arm he could bring up. And that was only doing a couple times, and I was like, floored. And later on, when I was leaving that day, he goes, look, I can raise my arm up. And I'm like, that was
too easy.
Easy is the word. Yeah, but I've tried it with some other people because I work in a geriatric rehab setting, and they're like so locked in here. And I'll say my twist, and it's like here, and there's nothing, and it's kind of getting stuck with some of that.
Sure. Yep. You'll just have to go to other gooder parts. So good. Excellent.
Yes.
All right. So let's take a break because you guys have been sitting there a bit, and then we'll come back and get to some doing this. So we're going to actually physically do. But before I do, does anybody have any other questions? Yes.
You know what about if somebody has really neurological problems from a ruptured disc and it's like like that disc, like a rock on that nerve root. And like when they do the MRI, and as you said, the surgeon said there is no way you will not function. We need to get that, discectomy. We need to get that rock, like that disc pressing on the nerve. You cannot get better, and that's all.
So you get those patients, right? Do you ever get them better? Do you ever get them better?
95%, yes.
Good. So you
But-
get them better. So the thing the doctor said wasn't necessarily true, correct?
Correct.
Okay, so good. Now, because you're using myofascial stuff, you're doing something for them. Now, look, if you take a psoas and it's tight and you work on it, you get it looser. Okay, now, I've shown this again to visceral manipulators and myofascial manipulators. I said, that's great, but before you treat them, let's test the bad twisting, good and bad twisting. All right, and we find out that that's the bad twist. So you go down and do myofascial release on them, all right, and trigger points, whatever you want, and this gets looser, and we call it 70% better. Well, as soon as I take them back to this side, let's say you got it down to a 20, it shoots it back up to a 60. What we find fascinating, though, is that when we take the correct direction and we go to the left and we keep doing it and we waited in between, like 10 minutes in between, then we twisted to see what happened. Just like they got in their car and went and twisted or something. So we did that, and this hung out like at a 10. And the amount that came back was a lot less. So continue to remember that, again, hands-on stuff's awesome, okay? It's highly necessary at times. But with the same thing that you get them better, right? Motion, anybody who comes in with you, unless they're wheeled in, has motions that they're able to do. And you've got to take cerebral palsy kids and see them change. And if you want to see one, we can look at it later, of a kid that massive changes. He's out jumping around and stuff now, and he was being fitted for a wheelchair. Major changes of torticollis that's happening, stroke patients. We had an OT and a PT that got trained in Texas. Both went to the same seminar, both worked at the same hospital because we were training for the hospital. And went in to see a patient that was, 24 hours, 48 hours post-stroke, awake and alert or whatnot. And the OT decided not to try the TMR on. PT came in and goes, oh, what the hell? The son is sitting there, has the patient, it's got the, kind of dead arm, goes over to this side, lifts it up. I think she might have done a twist or a leg raise, probably not the leg raise, maybe a twist, and this arm went up. Everybody's mouths dropped and stuff like that. Again, from a neurological perspective, from the plaque on the brain, that should not happen. I'm not denying that the infarct was caused and showed up this stuff on the brain, but no longer does a neural concept now equate for why that just happened. And you'll see those things. And it's just phenomenal in the children that are changing. I mean, just beyond belief. So that stuff, as far as what a doctor says, the biggest part of that when a doctor comes and says that to the patient now, it's now in the patient's brain. Because what the doctors basically said, there is nothing else for you, right? And so you're going to meet resistance. And that's what we meet, whether you're doing it massage-wise or we're doing it motion-wise. It's that block. It's not, we got to get past that block before we can actually get them better. They still get better. Good? Is there any questions or anything online?
A couple people said that it makes sense because everything is interconnected. Another one says, it definitely inspires me to think outside of the box and be creative.
Excellent. All right, so let's stop here, pause it.